Hi, I'm Dr. Dan Margolin. So today what we're going to do is go over the treatment course estimate form, but in terms of scheduling, right? So the patient comes in, we've already reviewed that you've done an x-ray, you've done an ultrasound, you've determined that they need a lodi taping. Now what do? Now based on their response, you go with the treatment course estimate form, which will break the treatment course into different columns based on how they respond. So the next few videos, what we're going to do is just simply take each column one by one. All right, so the first one is going to be the patient that comes back. They came in with, let's say, plantar fasciitis. You did a lodi taping. On the initial visit, here's what you did, right, on the calendar. You did an initial visit. You did an x-ray. You did an ultrasound. You do the lodi taping, okay? Now, you ask them to come back 2 days later, and they come back and they say, hey, I'm 95 to 100% better. Now what do? All right, well at that point, you would, one, make them an orthotic, two, give them an air heel, three, you might even tape them up, do like a lodi taping. The concept here is to keep them immobilized. It usually takes about 2 weeks to get the orthotic back. So, you know, one of the questions they'll ask is, what should I do in the interim? Now, every once in a while, I might still do one cortisone injection, but usually not. Usually, for this person, what we will do in the interim of waiting for the orthotic is start them on physio. Physio would include TENS units. It would include ultrasound. It might include laser therapy, whatever the components that you would use almost in like the physical therapy. And so they would come in, let's say, on a Wednesday, and then you would do the orthotic, and then 2 days later, you would do physio. You would bring them again back the following Monday, and then the following Wednesday, the following Friday, again the following Monday, and these are for physio. At about 2 weeks, they would come in to pick up the orthotic, and then they would again, the following 2 days later, they would have physio. And then about a week after the orthotic was picked up, you'd have them come back just for an orthotic check, right? Just to make sure that the orthotics are comfortable. Okay, now the orthotics are comfortable. The next thing we want to do is really increase the flexibility of the plantar fascia and the Achilles tendon, and we use a night splint for that. We spoke about that in previous videos. And usually we will see them back at about 3 months for that. So for that, you're seeing them roughly about 11 times over the course of the month, and usually they just do great with that. Okay, so that is for the 95 to 100% improvement patient with that lodi taping. Okay, thank you. All right, we're going to continue now with the treatment course estimate form, except now we're going to go to the second column where the person comes in with 80 to 95% improvement with the lodi taping, and we're going to carry on in terms of scheduling and how we would actually schedule this person out. So basically they would come in, let's say on a Monday, you would do the initial visit, you would do a diagnostic ultrasound, you would do an x-ray, and you would do the lodi taping. You would then schedule them about 2 days later to come in. They come in and they say, Dan, I'm 80 to 95% better. And you say, great, that's awesome. So what we're going to do is make you an orthotic. We're going to do usually an air heel to stabilize them. And usually at that point, we will also do a cortisone injection. Now, here's the thing. We're not necessarily going to do physiotherapy on this person because it's a little bit harder to actually get them to really buy into the physiotherapy because they're going to get several cortisone injections, and usually they consider that to be the treatment. Usually their problem is not quite that severe. They've responded fairly well. So what we would do is, again, 2 days after the initial visit, they're having the orthotic made, they're getting an air heel, they're getting a cortisone injection. Then 1 week later, we bring them back for another cortisone injection. All right? And then we bring them back another week later to pick up their orthotics. And then, now they should be usually, if they're 80 to 95% better, what we find is usually 1 to 2 cortisone injections does very well with the person. You can also use Traumeel or Sarapin. We don't use that particularly, but certainly that should work. They then come in, they have the 2 cortisone injections, then they pick up their orthotics, and then a week later they come in for their orthotic check, And again, you give them a night splint to get that flexibility, and then we would follow them in about 3 months. So you see them a little bit less times, though the visits are, you're doing a little more things actually in terms of production, the cortisone injections, etc. So that sort of wraps up the scheduling for the 80 to 95% on the treatment course estimate form. Thank you. All right, so now we are here for the treatment course estimate form. Today, right now, we're going to work on that third column. Here we have the individuals that are 50 to 80% better, right? So they come back after you do the initial visit several days later, and they're saying, hey, I'm about 50, 60, 70% better. So they're not quite as good response as the last two. So now we're going to look at how we schedule out these people. And so they're 50 to 80% better on the Monday, on that initial visit, right? You do the initial visit, ultrasound, x-ray, low-dye taping. You bring them back that Wednesday. We make an orthotic, an air heal, and a cortisone injection. But now they are a little bit more of a serious situation. We talk to them as such, and we say, look, we've got to be a little bit more aggressive. We absolutely are going to do physio, and we're going to start bringing them in on that Friday, and then that Monday, and then they're going to come back on that Wednesday, right? This is a week, almost directly 1 week after the orthotics were made, the air heal was done, and that first cortisone injection. And now they're going to come in for a second cortisone injection. We're going to see them several days later for a little bit of physio, and again on that Monday. So it was the cortisone injection. That Friday was physio. The following Monday was physio. We bring them back now on the next Wednesday, and they are getting the third cortisone injection. They're also picking up their orthotics at that point. We then, 2 days later, they come for another physio, right? And then a lot of times we'll do maybe on the 23rd, another physio, and then boom. 1 week after they've picked up the orthotics and their third cortisone injection, they come in for a orthotic checkup and a night splint, right? Very similar to all the other things. Now, here's a point. If they're not responding at this time, if they come in and they say, you know what, I actually don't feel better, and we've given them 3 cortisone injections, at this point, I would actually give them a cam walker or a walking boot, immobilize them, and immediately get an MRI, okay? Then based on that MRI, you could make some decisions. What you're looking for with the MRI, or what you're not looking for, is stress fractures. If there are stress fractures, you would immobilize them. If there are no stress fractures, then we probably are looking at a situation of what's called plantar fasciosis, where there is just a non-healing of the plantar fascia. Again, you'll probably see that as some tears in the MRI, and you may consider the amniotic allograft injection at that time. But let's assume that after the third cortisone injection and the orthotics, they're doing well, you've given them a night splint, then we would see them in about 3 months just as a follow-up. All right, so that pretty much summarizes the person that is 50 to 80% better with the treatment course estimate form. Thank you. Okay, so now we are looking at the treatment course estimate form, and now we're looking at those people that come back 0 to 50% improved. Now they're not really, some of them are not improved at all, or some of them very slightly. So let's talk about how we schedule these people out. And again, this is the person that has not responded as you would particularly like, right? You've done the low-dye test, they're coming back, not much of a response. So on the initial visit, you do the ultrasound, you do the x-ray, you do the low-dye taping, you bring them back 2 days later, and they're like, yeah, I'm not any better. At that point, we put them in a soft cast. It's called a Jones compression dressing, where basically it's just a soft cast below the knee, usually relatively short. And then you bring them back about 3 days later and put them into a cam walker. The soft cast, what you want is that compression initially, and you don't want them to have the option to really take it off. This is really what you're trying to do, is more aggressively immobilize them and keep compression on them. And then they'll wear that cam walker. Maybe they'll come back at about 11 days from the initial visit. They've been immobilized at that point for about 11 days. It may even be 11 days from that. I'm sorry, the point you put that soft cast on. Usually it's around that point. It does take about 11 days for soft tissue to heal enough that it doesn't easily re-tear, so that's really the concern. At that point, you can take the cam walker, the walking boot off. You would make them an orthotic. That's going to be for the long-term treatment. You may give them an air heel, because now most probably going to start to want to get them out of that cam walker, but we don't want them to go back completely to what they were doing, and we've got to, you've got 2 weeks to get that orthotic back, so in that interim, we want to keep their arch up, we want to keep them posted, so we do an air heel. We may consider cortisone at this point, right? It's almost like at this point, I would start them as if they were at that 50% to 80%, right, where you do 3 cortisone. So you're giving them cortisone, you bring them back in another week for another cortisone. We also can start them on physio in the interim of this too. So they come out of, so going back, they come out of the cam walker, you've given them, made an orthotic, you've given them a cortisone, you've given them an air heel. Several days later, you bring them in for physio, then you bring them in for their second cortisone injection, you bring them back for some more physio, then you bring them in for their third cortisone injection, and then to pick up their orthotics. They'll be probably doing that around the same time. If they're not responding at this time, again, an MRI with that same concept. You're looking for stress fractures, right? If they're not if there is no stress fractures, then you may consider amniotic allograft injections, among other things. Now, a week later, so now we're extending this a little bit, right? Before we were in October, now we're in November here, and we're looking at an orthotic checkup and the night splint. And assuming they're doing well, we would see them back in about 3 months just for a follow-up. So this is for the person that is 0 to 50% better. Again, they would come in on the initial visit. When they do come in 2 days later, we're putting them in a soft cast. Several days after that, we're switching them over to immobilization with a cam walker or walking boot, and then they're in that for about 11 days, and then we start with the almost like the same protocols as the 50 to 80% better, where they're getting about 3 cortisone injections and going from that point on. Okay, and that wraps up the 0 to 50% improvement. Okay, and now we're going to go over the treatment protocol, treatment course estimate form on someone that comes in worse. Right now, the person, you've done a low-dye taping, and they're coming back and they're actually worse off than they were. They're complaining of the pain, and what do? So in terms of scheduling, same thing. You have your initial visit, you have the ultrasound, you have the x-ray, and you have the low-dye taping. They come back 2 days later, and they come back and they're worse. So what do? You put them in a soft cast, and I would at that point immediately order an MRI, have them come back several days later to get a removable cam walker. If they are going for the MRI, they may remove that soft cast at the MRI. If they haven't gotten it yet, you're going to give them a cam walker several days later. So probably several days after the MRI is taken, they're going to come in to review it, and based on what you find is going to determine what's going to happen. If it is stress fractures or something like that, you would continue them in the walking boot. If it's plantar fasciitis, you would consider the amniotic allograft injection, and you would basically go from there. So those are really the delineations that we use. It's a very systematized approach to patients. It gives you a very good idea not only how to treat the person, but how to schedule them, and I hope that helps you out. Thank you so much.